Geriatrician. I'm director for the OPH Clinical Support and Community Services. And it's with great pleasure today I introduce Dr. Ian Sturgess, who has come at short notice for a lightning analytical tour of our facility. And Ian's shouldn't need an introduction, but he'll get one. He's by nature a geriatrician.
Hey guys, we can't hear you. It's Jane here.
Okay.
Could you turn yourself off mute?
Can you hear me now, Jane?
Thanks.
All right.
Yeah, lovely. Thanks, Steve.
I'll start again. We've got Ian Sturgess with us here. I don't know if you can see him on the screen because I can't see what you're seeing.
We're seeing just what we're
They're probably seeing the back of Ian, but you'll see him later.
No, we can see the presentation.
Right. Okay. Can you see me?
No, they can see the person.
Yes.
Oh.
Picture in picture? Okay. Ian's here for the day. He's going to give us some thoughts about how our hospital systems and services are structured from his point of view. His expertise is in patient flows, not just for older patients, but across the board. Ian's had an opportunity to visit parts of the hospital today already and meet a few folk. He's been in touch with ED, internal medicine, and with the Older People's Health Service. He's met staff from all those areas, and what he'd like to do is give us a brief presentation on things which he thinks is pertinent to his visit here, and then we have a chance to talk further about that and what he's going to advise us on. Okay, the floor is yours, Ian.
Thanks very much. If I just expand a bit on who I am and why I think I ought to be here to talk about it. I've been a consultant in the UK for 20 years, a clinical director of geriatrics, a clinical director of medicine, an associate medical director and a medical director. I've worked with over 150 organisations over the last 12 years in improving safety and flow in urgent emergency care. Predominantly in the UK, but some in Australia and some now in New Zealand. The key thing from my point of view is the driver for all of this is about patient safety and experience, because that's the thing that gets me up in the morning. Other sort of targets and things don't get me up in the morning, but it's actually about patients' safety and experience. We can put that onto the slide presentation part of it. So I worked with the Modernisation Agency, and I worked with the NHS Institute, and I helped set up the Emergency Care Intensive Support Team in England, which was set up to help support organisations that were challenged around emergency care, safety and flow. And my journey, if we just go down to the next slide, please. My journey starts by what drives me, and it is all about patient safety and experience and flow. They are not mutually exclusive. If you have poor flow, you have poor patient safety and you have dreadful patient experience. And on the right-hand side of the slide there, you'll see the IHI pursuing perfection statements of, we should be aiming to eliminate avoidable deaths, reduce harm, no unnecessary pain, no waste, no delays, no feelings of helplessness, no inequality, and aiming to get everybody on the same page. This is not about hitting a target. I can get you to hit the target tomorrow, the 6-hour target, if you wanted me to. It will be a dreadful experience for absolutely everybody, most importantly for the patients. If you want to do it where you reduce harm and reduce mortality, anybody here not want to reduce harm and mortality? Good, nobody put their hand up, I'm really delighted about that. You can do it, and as a consequence of doing it right, you will then hit the 6-hour standard. And one of the problems in the UK is that the performance metric, so-called performance metric, the 4-hour standard, became the outcome metric, rather than actually saying, let's get the quality of the care right and the timeliness right, and as a consequence of that, we deliver the 4-hour standard. And when you do it that way around, you deliver it very sustainably, extremely sustainably. It's not immediate, and it's as fast as you're prepared, as hard to work at it. But since in any system that's overcrowded, patients are coming to avoidable harm and potentially avoidable death, there is a certain degree of urgency about wanting to change it. So if we go on to the next slide, and this is slightly confusing to me. Can we get rid of this picture at the top, because it cuts out half the slide. Every system is perfectly designed to deliver the results it's achieving. And your system, from what I've observed today, and because I've done this so often, me looking at a system is like a cardiologist reading an ECG. It's good pattern recognition. Your system is absolutely perfectly designed to be delivering the results it is currently achieving. And if you carry on working the way you are working at the moment, you will absolutely consistently deliver the results that you are currently achieving. Okay? And if you want to reduce overcrowding, you want to reduce harm, and you want to reduce potential avoidable mortality, you've got to change the way that you're working. If we go on to the next slide, please. And if I just give you let me just do this. Up there. It does have some sound. In 2002, we had secret filming in one of our emergency departments where I worked. And this was what our corridors in our ED looked like. We had 96 patients lying on trolleys for up to 5 days. Our system was perfectly designed to deliver these results. It's shocking. And you'll hear things in the press about the crisis in emergency access in the UK at the moment. I go, crisis? It's nothing compared to that. You know, we have, if you were to reset our standard as 6 hours, and compare it with New Zealand, our performances across the whole of England is better than that in New Zealand. Okay, so our crisis is because we've got a nice tight standard, as it were. But that's what it was like. And the 4-hour standard helped us to change the processes to get this right. It wasn't the outcome metric, it is an integrated process metric. Have the next slide, please. That is exactly the same emergency department 9 months later in November. Cold November in 2002. We promised the system tumbleweed in the corridors of our emergency department. And we just got rid of all the waiting. And guess where all the improvement was? About 2 to 5% was in the emergency department. 95 to 98% of the improvement was downstream of the emergency department. And if you don't address flow across the total journey time, you will never, ever solve this. And if you compartmentalise it and salami slice it and point fingers around the system, it does not work. The 4-hour standard and the 6-hour standard are a measure of how effectively your system is working as an integrated system. All right? It is not a target, it is an integrated process metric. Emergency care is extremely predictable. It is more predictable than elective care. Do you know why it's more predictable in elective care? Because we don't mess about with demand. In emergency care, the community generates the demand. In elective care, how you book your lists, how many people here are a surgeon? How you book your lists, you mess up demand and then you mess up the supply side. So there are 2 variances that you add. So the variance in elective care is wider than the variance in emergency care because we have 2 opportunities to mess it up. Emergency care demand is extremely predictable. Your ED attendances, this isn't your ED, this is another ED that I'm presently working with. Your ED demand starts to pick up at about 9 o'clock, half 9, peaks at about 12, 1 o'clock, stays fairly constant till 8, 9 o'clock, 10 o'clock at night, then slowly falls off and then falls off quite steeply after about 12, 1 o'clock in the morning. Why can I say that without looking at the slide or even looking at your data? Because in 150 organisations that I've worked with, it's exactly the same in the same 150 organisations. So emergency care is extremely predictable in its totality of its demand profile and therefore is totally manageable. And if you do that just ED arrivals or those patients who are arriving who then get admitted, it's exactly the same time profile. It is extremely predictable. So demand is very predictable and we just have to understand what capacity actually is. How many people here think that beds are capacity? I'm so pleased nobody put their hand up because you knew what I was going to say. Beds are not capacity. Beds are where patients wait for the next useful thing to happen. Anybody know the randomised control trial of the hospital bed? There isn't one. So there is no evidence base for the hospital bed. Anybody know the randomised control trial where delay in initiating appropriate treatment improves the outcome for somebody presenting with an emergency condition? Is there one? There isn't one. Do we create delays in the initiation of appropriate treatment for some of our patients? Yes, we do. So why are we contradicting the evidence base? So we just got to get rid of the unnecessary delays in commencing the initiation of appropriate treatment for our patients. Next slide, please. I always look at this from the patient's perspective. If you're getting admitted to hospital, or coming into hospital as an emergency patient, you are at your most disenfranchised, most depersonalised ever. It is an extremely frightening experience. What do we do to that experience? We add more and more confusion, which is extremely demoralising for patients. Every patient who gets admitted, or their relatives if they don't have capacity, should be able to answer these 4 questions from day 0. What is wrong with me, or at least what are you trying to exclude? That's a decent assessment by a competent clinician. What is going to happen to me this morning or this afternoon and tomorrow to get me fixed? That's the case management plan. and that's designed by a senior clinician. What needs to be achieved to get me out of here? Because anybody know many patients who really want to stay a long time in hospital? There are occasional ones, but most patients just want to get out of here, and let's give some certainty to them. And when is this going to happen? The expected. So that's what needs to be achieved to get out of here is called the clinical criteria for discharge. Surgeons, elective surgeons particularly, are very good. How many? You run an enhanced recovery program here. This is all about enhanced recovery for non-elective care. Enhanced recovery is exactly the principle. It's about creating expectation. We just need to create expectation in non-elective care. So, and when is this going to happen? The expected date of discharge. And that's no decisions about me without me. And if I was to go onto your wards, and I haven't done this, and to ask each and every question, every patient, those 4 questions, what percentage of patients do you think on a non-elective pathway could answer those 4 questions with confidence? Very few, less than 5%. Okay, it's a very depersonalising experience, you know. And then we come to the day we're going to send them home and say, "Well, you can go home for something." Well, I'm not ready yet, and discharge becomes a surprise. Next slide, please. Occupied beds, as I've already said, are inventory. Patients waiting to get processed. Beds are where patients wait for the next useful thing to happen. Do you use average length of stay to monitor the performance of your system? Do you use average length of stay?
Mm-hmm. Yeah.
Yes and no?
Yes.
It's the most useless metric ever invented in isolation. I can decrease your average length of stay and increase your bed occupancy by admitting a whole load of people who never need to be admitted. They'll have short length of stays, average length of stay will fall, da-di-da-di-da. I can increase your average length of stay and drop your bed occupancy by moving a large chunk of patients who traditionally get admitted but moving into ambulatory emergency care and a non-admitted pathway. Of those who remain being admitted, their average length of stay will be higher, but bed occupancy will be lower. So average length of stay in isolation is a completely pointless metric. As a generalisation, in conjunction with other metrics, it's usually
Occupied bed days.
Occupied beds, actually. How many people have you got in
Occupied bed days.
Yeah, occupied bed days. The key thing is having live metrics that tell you how to manage your business today and tactically 7 days forward. Yes. The problem with occupied bed days is that's usually a retrospective metric because the patient has to be discharged before the totality of the occupied bed days are calculated for each episode. So it's a retrospective metric. If you want to manage a business, so the post office doesn't want to know how many parcels it delivered yesterday, it just wants to know how many parcels it needs to deliver tomorrow and make sure it needs to get them delivered. So real-time metrics, both daily and hourly, that allow you to predict what's going to be happening is the way you manage a business. So that's a statistical process control run chart showing an average number of, the actual number of beds occupied. And it'll be the same here. Look at that great bit. This is patients who are admitted on a non-elective pathway. Great big spike down there. What day is that? Christmas Eve. Isn't it amazing? Everybody gets better on Christmas Eve. So that's special cause variance, and what we need to go is, right, what things can we replicate that happens on Christmas Eve that we can replicate across the systems. You don't normally change a system in response to special cause variance unless it's a positive special cause variance. And this was Leicester, and they've set their aim to achieve their bed occupancy down to what they were achieving at Christmas Eve. That's their aim statement about what they're aiming to achieve. Is there only one surgeon in the room? No. That's a shame. One of the things that we did in East Kent was I gave a promise as a clinical director of medicine to the clinical director of surgery that we would not outlie into surgery again, and we didn't do that for 8 years. You're outlying all the time, medicine, nearly all the time, medicine to surgery, and it has an impact on your ability to bring in elective patients, I am sure, and certainly your tertiary referrals. Next slide, please. So what is the goal of admitted emergency care? Is it to maximise income? No, it doesn't maximise income. Does it? Yes, of course it's there to treat patients safely. Is it to get patients back home having achieved an improvement in their acute condition? Yes, but that's a bit long. Actually, it's about delivering the expected date of discharge and clinical criteria for discharge, i.e. the enhanced recovery for non-elective care. And unless we actually set our colours to the mast, as it were, to say what we're aiming to achieve, and then manage it within an inch of life so that patients have no delays in their pathways. And I've been observing on some of the wards and saying, I've seen numbers of waiting for on the boards. Completely unnecessary. You've got to manage those waiting fors out of your system. Next slide, please. So, as I say, I'm a geriatrician, so I can see things a bit like a surgeon, actually very black and white. Okay? Yeah, what adds value to emergency admissions? Timely senior assessment. The NC pod report, National Confidential Inquiry into Patients' Outcomes and Deaths, over the last decade in England has demonstrated very clearly that if there's a delay in timeliness of a senior review by the admitting specialty, you have a worse case management plan and your outcome is worse. Okay? So timely senior assessment, and that should be as close to the point of access as possible. And I know I'll get the challenge, but we're a teaching hospital, we've got to train people, and I'll answer that one by saying you should only be a teaching hospital when you deliver brilliant care first, and then you wrap brilliant training around brilliant care. So let's deliver brilliant care first, and then wrap brilliant training around brilliant care. A timely end-to-end case management plan, which is an enhanced recovery end-to-end case management plan, which is home to home, what's going to happen, when it's going to happen, where it's going to happen, and communicate effectively so the tempo is set from time zero. And then ensuring the timely delivery of inputs, not just saying this person needs a CT scan and then walking away and coming back on your ward round 2 days later to find it hasn't actually been done. Saying, oh, this person needs a CT scan, it's discharge critical, it's going to happen today. And making sure all of those things happen in a timely manner, and that's about redesign of your processes. And then maintaining the tempo, so daily review against plan. So if a patient starts negatively deviating from their plan, you can intervene early before they deteriorate too far. So I'm going through this very, very quickly to stimulate a discussion, but there's a lot of detail behind this. How do you make this happen? How do you change the processes? And I've seen in some of the offices A3 reports and PDSAs or whatever, and using an embedded improvement methodology is the key to all of this. But it is deliverable and it needs to be done at pace. Next slide, please. So this is the traditional model for acute care in many hospitals. And I could salami slice this into many different ways for here. So you have GP referrals, A&E referrals, into an assessment unit, which you don't have an observation unit, then you have short stay units or specialist units, multiples of those. And every time there's a handover, there is a delay in the patient's care. And one of the worst things that can happen is specialty ping pong at the point of A&E referral to a specialty. It absolutely destroys flow. And it is one of the first things I recommend must be absolutely banned in every organisation that I work with. It is extremely dangerous and consumes a huge amount of time and is not good for patients. A&E departments, ED departments are very good at deciding which specialty, as long as it's not made too complicated about how many multiple subspecialties you've got to refer to. And we need to sometimes simplify our referral pathways, because if you salami slice the referral pathways, you really do start getting confusion. But specialty ping pong, this is a very special plea from a non-ED doctor, and needs to be banned. If you are going to be really serious about improving safety and experience for the patients, forget about the 6-hour standard, but about patient safety and experience, you need to ban specialty ping pong with appropriate methodologies. You've got a relative senior referral process, etc., etc. But every time you have a handover, and there's specialty ping pong throughout patients' journey in this organisation, as far as I can tell at the moment, I haven't done a full analysis, that delays patients' recovery time. Next slide, please. I'm just going to talk briefly about expected dates of discharge, because what I can do in this talk is do a very long presentation with lots and lots of statistical process control run charts, which normally switches lots of people off. Okay? But I just want to talk about, if you get admitted, you need to have an expected date of discharge and clinical criteria for discharge. And people get very worried about setting an expected date of discharge. It's actually very simple. You set it assuming that everything goes perfectly according to plan, there are no internal delays, no external delays, and patients recover according to plan. So therefore you make sure that when you set it, you do not embed the unnecessary delays. So when you first start using them, you'll only hit it about 10% of the time, because you haven't designed out the unnecessary delays. How many people here know about theory of constraints as understand? Right. So this setting EDDs and clinical criteria for discharge is setting up a process where you can start collecting what the constraints are, and then you can address the constraints in day, and if they keep on being recurring, you then have a redesigned process. Absolutely crucial. Clinical criteria for discharge is what does the patient need to achieve to get out of here? Dead easy for an asthmatic patient, it's a peak flow. For an 85-year-old who's got a functional impairment, it'll be a functional assessment, so how far they need to walk, if they need to go from their bedroom to the toilet or whatever. But it's crucial. Those two together are a clinical coordination instrument. And they allow me as a consultant to hold everybody else to account, to say, right, at the board round, you're doing this today because we're going to aim for that, we're aiming for that clinical criteria, we need to have this assessment done today, that MRI needs to be done today, that needs to be done today. We all need to design to make this happen. If there are constraints and we can't deal with it, you then have to go back to design and design them out. Because, as I was saying earlier on, your MRI waiting list is not rising continuously. And therefore there is not a demand capacity mismatch, sorry, a demand oversupply. What you have is demand capacity mismatch if you've got delays. So sometimes you miss slots, and we haven't invented time travel in health service yet. If we could invent time travel, we could go back and use wasted capacity. Next slide, please. This is a way of looking at length of stay. Far better than average length of stay. It's not perfect, but it's looking at the admitted flow streams. And there are essentially 3 or 4 admitted flow streams. There's ambulatory emergency care, stroke, short stay. There's sick mono-organ specialty. There's acute frailty, and then there's the hypercomplex. People who normally need to go straight to ITU, either the polytraumas or the multi-organ failures. I'm not going to talk about those rare strangers today. I'm just going to talk about the first three groups. If we just go on to the next slide, please. And it's very clear about how you need to maximise their management. And they need to be managed by expert teams as close to time zero as possible. Not the next day, as close to time zero as possible. Because if you don't start the case management plan for the admitted patients effectively as close to time zero as possible, and you waste the first day, you just keep on adding to that length of stay. So for frailty, for instance, my area of expertise clinically, how many people here know what rate you can lose quadriceps power generation, not strength, in the first 12 hours of a hospital admission? You can lose 5% of quadriceps power generation in the first 12 hours. My research is in muscle physiology. If you lose 5% of your quadriceps power generation and you're frail, you can be converted from somebody who's just about mobile to being requiring 2 to transfer. And if that happens, you then got a long length of stay. Guess when you lose most of your functional reserve when you're in hospital? Is it because of the acute illness? It is if it's catastrophic, but the vast majority of frail older people actually are admitted with mild to moderate acute illness. It's the hospitalisation that causes the decompensation, that causes huge extension of length of stay. But for specialty patients, if they truly need to be under a specialist, they need to be under a specialist on day zero. But that means being seen by a consultant on day zero, not the next day. But what you need to do is to decide, do we need to massively salami slice our capacity by having multiple takes for patients? Because the poor ED, if it's got to say we need a right ventricle cardiologist as opposed to a left ventricle cardiologist referral, and it takes them longer than half an hour to respond, and I'm going to stress the 30-minute response time to ED very much. If you want to be on call for emergency take, you need to be able to respond to ED in 30 minutes. If you don't want to respond to ED within 30 minutes, you have no right to remain on the on-call take. Okay? Because if you want to be running a specialist take, you need to be responsive to the service, responsive to the needs of the patient. So if the patient truly needs a specialist input, then it needs to be in there within 30 minutes and then dispersal within 30 minutes. Because if it can wait until the next day, is that patient truly a specialty patient? They're not. If it can wait until the next day, you're not a specialty. Okay? You cannot be a specialty if the patient can wait until the next day, if that's been their specialty presentation. But the key thing about all of this is how do you make sure you optimise each of those flow streams, because there are just those 3 or 4 flow streams. How do we make sure that we optimise those lengths of stay, their inputs and their recovery times as quickly as possible from day zero? So as many as possible of the short stays can be tipped over into ambulatory care. A significant number of this group and quite a few of this group can be moved over into short stay, and we massively shorten the risk of decompensation in hospital for frail older people. In East Kent, I showed you that video where we had that overcrowding in our hospital. Go forward 5 years from then, we had shed 450 beds, and our flows were better, because we'd got rid of the internal constraints, and we recognised, certainly for frailty, we need to get rid of the frailty, certainly for specialty, if you really truly needed a specialty input, and only a very small proportion do, you need to get it on day zero from a senior doctor, a consultant. Next slide, please. That's quite challenging, because the challenge that people come back with is, well, we're supposed to be training people. Yeah, great care first, then wrap great training around great care. Because I can, when I'm on take and I'm seeing patients, I can say to the registrar, you go and see that patient, and I'm going to watch you seeing that patient. You've got 30 minutes to make an assessment, and I'll give you immediate feedback. That's great training. That is really brilliant training, because they're getting it in day. So looking at the flow streams, short stay segmentation, short stay in ambulatory emergency care, that requires decision makers who see the patients very quickly and make very rapid decisions. Go, right, this patient can be either ambulatory or only stay in less than 3 days. And that's, in the UK, that's the preserve of our acute physicians. Okay, that's what our acute physicians are really good about. They're a bunch of specialists in internal medicine who are focused on short stay. 65 to 70% of the medical take should be out in 3 midnights or less. Ambulatory emergency care, which is patients not staying in overnight. So in one of the units in the UK at Middlesbrough, 70 to 80% of their diagnosed pulmonary emboli do not stay in overnight. They go home and they have great outcomes, okay? Because we know that they can be managed effectively in the community. You just have a risk stratification model, either based on a troponin to measure right heart strain, or an echo to measure right heart strain or whatever, and decide who needs to stay in. So that's generalist skills and standardisation. Next slide, please. For those who truly do need a specialist input, there should be an immediate response time of 30 minutes to that patient, and they should pull the patient straight away. Okay? If you can't respond within that 30 minutes or to an hour, then it's not a specialty service. It can't be. Because if the patient has a specialty need, they have it from time zero. They don't have it the next morning. It's from time zero. And there are common constraints, so specialist decision maker availability, so you need to move to an attending model maybe, or specialist diagnostic or intervention process. In many places actually, there are only 2 or 3 specialist services that should be on the general medical tape. There's obviously general internal medicine, cardiology, respiratory, and maybe gastro. Okay? Salami slicing your capacity into multiple specialties completely wrecks flow. And who ends up holding the bag of the patient who hasn't moved yet? It's the emergency department. And the emergency department, if it's got 25% of its cubicles occupied by patients who should be elsewhere or been referred on to specialty, they are completely unable to do what they're supposed to be good at, what I call type A behaviour, time to nurse, time to doctor, time to decision. They're completely unable to do it because they can't get the patients into an area to assess them. Okay? So this is completely dependent. 95% of your improvement to get your flows better and to reduce your bed occupancy so that you don't have medical outliers on surgical wards is all down to downstream flows. It's not down to the ED. Next slide, please. Sick frail needs planners and decision makers, and the key thing here is to avoid deconditioning. As a geriatrician, it always used to dishearten me, but because now we're at the front and we control the process, we don't get it. When people used to say to us, well, we've brought them in, we've done X and Y procedure to them, they need a period of convalescence now. I don't know how convalescence is. And I'm going to see the patient, they're completely immobile in bed, having walked in to have their either elective procedure or emergency procedure, and we go, well, thanks a bunch, you caused this. So let's stop it happening in the first place. Let's stop the deconditioning in these patients. There's a huge opportunity for improvements in flow in frail older people services, and at the moment we've set up in the UK an acute frailty network around the UK to help deliver these principles across many more of our systems. But if you don't recognise the risk of early decompensation in frail older people, and we do that by being caring, in inverted commas, frail older person who's had a fall, we put them in a bed, we'll sort of say, you can't get up unless somebody's with you and whatever. They'll have lost 5 to 10% of their quadriceps power generation, and they are completely lost, and takes a long time. So this group of patients actually needs very assertive early case management. Do they need some fluids? Okay, give it, and then take the Ventolin out. Don't leave the Ventolin in because that ties them to the bed. Don't put catheters in, please. Frail safe. Once you've given them a bit of fluids and their postural drops are reduced, get them up out of bed in 2 hours' time to start walking. Because if you leave it until the next morning, you've lost the plot. So it's very much focused on assertive case management, and as it is in all those groups. And this is what can happen when you turn it on and then when you turn it off again. So this is a thing called the stranded patient metric. Patients age 75 and over who've been in hospital 10 days or more. This organisation switched on a frailty model and dropped its numbers of those beds occupied by about 50 in the space of a month or two, and then they stopped doing it. their bed occupancy went back up again. Okay? But you can do the same with all of those flow streams. So in ambulatory emergency care and short stay, if you tipped as many patients as possible from short stay into ambulatory emergency care, that gives you what's called in-day bed control. And therefore you have ability to admit patients to the right bed every single day. 8 years of no medical outliers into surgery. How many people would like to see that? The only people who can deliver it though are you, not me. It requires a very different approach to it, saying what adds value to patients, early senior assessment, early senior decision making, very clear case management plan, complete intolerance of any internal delays. You see the delay, you escalate it, you manage it, and you deal with it. Aiming to get rid of all those statements on your whiteboards that go waiting for MRI, waiting for echo. They're just not acceptable. Okay? As long as those waiting for MRIs and waiting for echo are necessary for discharge. Right? Because if it's, you know, I sometimes see patients waiting for an endoscopy because they came in with a pneumonia and the hemoglobin was 110, and their mean corpuscular volume was 65. They weren't actively bleeding, but now they're waiting for an inpatient endoscopy. That's not appropriate. That's something that should be done as an outpatient, as long as you manage the outpatient waiting process, that you know consistently that those patients will get their diagnostics done. Next slide, please. I'm just going to touch on daily board rounding, because you've got your electronic boards are almost perfectly set up to collect all your constraints and assist you in managing those constraints. But I don't think you're using them effectively. I mean, how many people here feel they're using their boards effectively to capture constraints? Potentially all the information could be on there. So daily board rounds are about saying, this is what we said we're going to do, and we're going to make sure it happens. And if somebody does negatively deviate from their recovery, we can intervene early. The nursing and medical director sets the principle. The clinical directors, and bear with me while about the hierarchies, the clinical directors describe and standardise the process, and they lead from the front. Okay? The ward senior clinicians, the consultants, the ward SMOs, ward managers and the AHAP leads demonstrate it, and the key thing then is to have peer-to-peer review. So in organisations that I work with, once they've set up effective board rounds, I get one team on one ward, going and observe another ward once a month, and give a bit of supportive feedback. It shouldn't be criticism. This is about a supportive challenge to improve everybody's performance. The trust execs or your DHB boards or whatever, and your non-execs that can have them, need to walk the floors and ask, are we doing this correctly? Okay, are we doing this properly? And management of disruptive behaviours. I'm sure we have absolutely zero disruptive behaviours. I'm sure everybody gets completely on board straight away with your improvement programme. It's about getting people to want to join the journey, and if they want to join the journey, what's the thing that triggers that? The thing that triggers that is patient safety and experience. But if there are truly people who are disruptive, they need to be managed. Okay? They have to be managed. Next slide, please. And the key thing to start this journey is acceptance. You have to accept that your emergency care pathway from front to back, or from community through the hospital back to community, is broken. That's a harsh statement, but until you accept that it is broken, you can't fix it. And our patients are at risk of avoidable death as a consequence. If you are a patient being admitted to an overcrowded hospital, you have up to a 30% higher risk of dying. Okay? Associated with it. Cause and effect hasn't been 100% proven, but if you do case net reviews of patients who have died in overcrowded hospitals, you see errors of omission and sometimes errors of commission all the time. Our patients are coming to harm. We know that if you're an outlier, you have up to a 50% higher rate of harm event rate. Patient's experience is poor. Waiting in a corridor or waiting on a ward, not knowing what's going to be happening next, is not a good experience. And they have recurrent uncertainty as a consequence of that. And everybody is working very, very hard. I'm not saying anybody in any of the organisations I go and talk to or work with, I never say, well, you're just lazy. That's not the case. People are working very, very hard. But guess what? You're wasting 30% of your effort. At least 30% of your effort. Because the amount of rework that you've got, or correcting errors when they've occurred. If you get it right first time, every time, and that's what you're aiming for, it doesn't happen straight away every time. It does work. Recruitment and retention is challenged. I don't know what it's like here from recruitment and retention. There may be other drivers for that. There certainly are around in the UK. And yet in any system that I work with, there are always those who wish to blame other people rather than fix the things they can. It is somebody else's fault. How many times do you see people going, it's their fault? There's one problem with that finger pointing. You've got 3 fingers pointing straight back at yourself. And we have got to get our side of the street swept clean individually to change things. And change ourselves, our behaviours, our relationships, and our processes. Actually, the most important thing to change is your relationship and your behaviours. And actually believing that you want to get it better. Because what we found in East Kent is that we had learnt helplessness and hopelessness to gold medal Olympic standard. We could blame anybody and everybody else, but we created it. And the people that led us out of that were the clinicians. Because we focused on quality, patient's experience, and absolutely rooting out all unnecessary delays in the system. Next. So fixing it starts with acceptance, the pathways are broken, that I am responsible, and that I is the collective I, that I am responsible for helping to fix it, is delivered by action, not by protracted debate. You don't fix this by committee. You fix it by doing something different tomorrow that's aligned to the things that add value to patients. Using known and effective changes, and I could give you a whole talk on all the things that I've seen people implementing. That's not what I'm here today to do, because it's just I've had insufficient time to look at every single element and I haven't had a chance to look at your data. But it does require peer-to-peer challenge and support, and a preparedness to say, are you saying that to preserve your specialty or your personal reputation, or actually are you doing that for the collective good of our population that we're trying to serve and the collective good of our DHB? Because actually at the end of the day, one thing that we needed to fix in East Kent when we had that secret thumb in our emergency department was our reputation. Because our reputation was in absolute tatters, and the only thing we could do was fix it, and we did. And our organisation was transformed over the next 10 years in what it aimed to achieve. And making not joining the improvement journey as socially unacceptable as drink driving. Okay? I don't mind if people are slower to take up new ideas and test things, as long as they join the journey. If people flatly refuse to join the improvement journey, or deliberately obstruct it, then that's a clinical governance issue and needs to be dealt with. And that's the process that many of us have used in the UK. If somebody has a better idea and wants to try it, it's permission to try, guys. If it improves the flow then and the safety, then let's do it. Next one. So, how do you set this up? You've got to have a burning platform. A 6-hour standard is not a burning platform. What really grabs people is patient's experience, the risk of harm and the risk of avoidable deaths. 95+ of your deaths in hospital will occur in the non-elective pathway. Therefore, the vast majority of your avoidable deaths and your avoidable harm will be occurring in the non-elective pathway. Who wouldn't want to start fixing that tomorrow? It has to be. That is the sense of urgency that we've got to generate. This is about our patients, not your patients or your patients, it's our patients as a collective. So that's creating a tension for change. Governance and leadership is about getting out there and saying to people, are we going to join this journey? Are you going to be part of this? Are you going to engage with the process? And leading a bit from the front and managing pushback and drift. Create a vision. I've asked today, can somebody describe to me what the vision of delivery of emergency care flows within this organisation is? Could I draw a map? What I try and do is, in my head, can I draw a map of patient flows? I would have a map with lots of squiggly lines on it. I'm sorry to say. It would have a lot of squiggly lines, not a criticism, it's because it's perfectly designed to do that. So let's create a vision about what good's going to look like with falling mortality, falling harm, increasing compliments, decreasing complaints, and patients feeling that they know precisely what's going to happen to them today and tomorrow, and don't come into hospital feeling frightened because they're not sure what's going to happen next. Enhanced recovery. And then communicate it. It's about walking and talking. I always say to executive teams, if you're not spending 30% of your time out on the shop floor talking to people saying, how's it going, any blockages that I can help with, you ain't going to manage the system. And then measure for success, and I haven't had a chance to have a look at the data that you're providing with, but I did ask 1 or 2 pointed questions, and I would suggest that some of the data that you're providing to the organisation does not help people drive their business. and it's about real time and being very clear about, it's all about quality and delivery for patients, because we know what adds value to patients. Data without observation creates assumptions. Observation without data creates anecdotes. Data plus observation, which is why I do both. It's like you take a history, that's talking to people. You do an examination, that's the observation. I ask for some tests, that's a series of data, and then I give a diagnosis and a prognosis and whatever. So data and observation is enlightenment. Next slide, please. And there is absolutely no reason that within your present resources that you could be achieving 0 medical outliers, falling mortality, falling harm, just by changing the way that you do things, by focusing very clearly on what adds value to patients. Okay? Trying to suspend a little bit about specialty empires or whatever, because I've experienced those in every organisation I go to. It's about what is right for the collective good of our patients. Because at the moment, with, I don't know how many medical outliers there are. 15. Yeah. And even within your present bed numbers, that can be brought down to 0 by the system changing the way that it works. And it's not just medicine. It's not, there's a little bit of ED, not just medicine. It will be surgery in its widest context about changing the ways they do things. But it is absolutely deliverable. And it all depends if people want to join that journey, because this is all about quality. And as a consequence of delivering that journey, guess what happens? 6-hour standard delivery goes through the roof. It absolutely guaranteed goes through the roof. But it's doing it in the right order. It's focusing on quality first and the target second. Making sure that we deliver the added value inputs to patients as close to the time that they actually need it. And I think that's the last slide. So, thanks very much. Any questions, challenges, pushback?
How do you think the culture of training and being excellent and then providing excellent training, how do you turn around that kind of thinking? This is a real dogma about that.
Well, I have to say I find it very difficult as a concept to understand that we don't start with delivering excellent care first and then wrap excellent training around it. So it's just a phrase that I think I would encourage people to use. If you're delivering high quality care and you then wrap high quality training around it, that's the best type of training possible. Because all we do if we carry on training people in the way that we're currently working is we're creating another generation of people who are going to keep on continuing that problem.
Correct.
And it's, I never ever, in that video, when we appeared on Tonight with Trevor McDonald, there is one clip of a consultant trying to examine a patient in the corridor in the ED, and that consultant was me. And I vowed that wherever I went, I would never, ever see patients waiting in corridors anywhere, because it's just a dreadful experience for everybody. You've got you can hide some of your weights in your ED, I'm afraid, because you've got, how many, 15 spaces? 15, 20 spaces?
And the acute.
Yeah, 15. So it's, and Peterborough, for instance, have got 30. Therefore, and Stoke have got 45. And they've just got people just waiting in the cubicles, nothing happens to them. And today, was it 10 of the 15 were waiting for patients to be reviewed, and 6 of those 10 were waiting for a decision from the specialist having been seen by them. That makes it completely impossible for the ED to do its job. So if I was to say to a cardiothoracic surgeon, you've got X number of coronary artery bypass graftings to do today, or whatever to do today, I'm going to come into your theatre and insist that you do 2 cholecystectomies. You'd tell me to bugger off, wouldn't you? Mm-hmm. Okay, that's what we're doing to ED. That's precisely what we're doing to ED. They cannot do their work if they've got everybody else's work in their department. And we've got to pull the patients through, fix them early, get them sorted, get them up, get them going, get them home as quickly as possible, getting rid of all the unnecessary delays. Mortality comes down, harm comes down. Readmissions initially go up and then they come down again as you get better at interface management. So be prepared for a slight rise in readmissions before it falls again. And that happens as night follows day in every single system that I work with, because we get good at doing the hospital and the discharge, but we forget about some of the interface stuff. We don't manage that interface expectation. Interestingly, the mortality fall is greater than the readmission rise. So I glibly then say to people, which would you prefer to be as a patient, dead or readmitted? But it is actually, in every organisation where they've had that improvement journey and they've delivered it, it's always the same metric. The mortality fall is greater than the readmission rise. But then they get better at the interface management and readmissions fall. Do you know what your risk of readmission is related to your length of stay? The longer your length of stay, the greater your risk of readmission. In every single system that I've worked with, the longer your length of stay, the greater the risk of readmission. Okay?
Why is that?
Because patients we make them dependent on us.
Right.
Simply put. And the other thing, those 4 questions that I gave you, that patients should be able to answer, pre-discharge, there are 3 more they should be able to answer. When I go home, what should I expect? So if the patient's had pneumonia, when you send them home, you should say to them, you're going to feel like you've been kicked by a mule for about a month. Don't think you can go out and do your shopping tomorrow or whatever. Because if you don't tell them that, and they find themselves very tired, a bit out of breath, go and do the shopping, what will they do? They'll come straight back to the ED.
Correct.
Okay? The second thing you should ask them is to tell them what to look out for if they are deteriorating. Okay, so if they've got pneumonia or they've had an infection, say, right, if X, Y, and Z occurs, you want to look out for that. And then you should tell them what they should do about that. Please don't tell them just turn up at the ED again, because if it's a specialty input, they should turn up to a specialty service. Okay, so it is about creating expectation post-discharge as well, and that's the thing that we're not very good at. So those 3 questions should be answerable at pre-discharge, and that will help mitigate some of your rise in readmissions.
That's really interesting because you look at the discharge summaries from an inpatient, and the last line is like, if you're feeling well, go to ED.
Where the buck stops.
Two things are going to be banned, that sentence, and specialty ping pong. It's not helpful.
I was going to ask you a question which you answered, but it sort of kind of ties in, is what percentage of ED bed occupancy by inpatient teams obstructs our flow, which you said was more than 25% of our acute beds.
No, sorry, 25% of your assessment areas within the ED.
What percentage?
If it's 25%, you're going above that, your ability to manage the flows starts to deteriorate.
And so I can tell you, and I'm sure my colleagues will agree, is entirely predictable, like patient presentations. Every single day, we will get to a point where there is 80% or more of our acute cubicles filled with people waiting to be seen or waiting for a process.
And
every single day.
The first starting time is to start setting what we call what the emergency care intensive support team is called internal professional standards. And if ED refers to a specialty, rule number one, no specialty ping pong. Rule number 2, 30-minute response time to come and assess, 30-minute response time to make a decision and disperse the patient. And you manage to that. Because if you think that you can just leave a patient waiting to be seen, then that's not an emergency care service. And one of the things that we do in the UK is if you don't respond within 30 minutes, we just move the patients, if they're physiologically stable, to your bed.
Wow.
We just do it.
Like I've worked.
We need to do things like that.
I suspect from my experience working in ED that a significant chunk of that time that those beds are occupied are not actually waiting for a decision. They've got a decision, but you're going through that whole admission process, because in ED, in medicine, the person seeing the patient down in ED does the full admission process and examination and everything while the patient's in ED, not up in the ward.
There will be a whole series of constraints to getting the patient.
That can take about an hour per patient.
Yeah.
But there will be a whole series about how long it takes people to assess them, how long it takes them then to make a decision, how long it then takes to get the patient moved onwards. I mean, one of the first questions which I didn't ask on the wards today, and I routinely ask in the UK, and I don't know how you generate them here, discharge drugs on wards. How many nursing staff have I got in the room? Do the nursing staff ever have to call junior doctors back to complete the discharge? Does that happen most days?
Yes.
Yeah? In Nirvana, that should never ever happen. Because if you do a one-stop ward round and everything's done as you're going on a ward round, you never have any delays in TTOs. And a 1 hour delay on a ward, patient leaving the ward, adds up to a 4 to 6 hour delay in the ED. So, how dare we waste patients' time by saying we're going to write lists of jobs. So the key principle on ward rounds is a one-stop ward round principle, where everything that needs to be done for the patient is done there at the bedside, unless it's a major procedure. And boy, does that improve flow. So you'll think I'm slightly a control freak here. Outside my office when I was a medical director in East Kent, there was a chair, and that chair was for the junior doctor and the consultant team who the nursing staff had reported to me that day hadn't done a one-stop ward round. It only got used 2 or 3 times because not many people wanted to come and see headmaster. Okay, because we set that as an absolute principle. Do your SMOs insist on having a nurse on the ward round?
Yes.
Yeah, and that's quite right for good exchange of information. Okay, professional courtesy is to make sure that the nursing staff then don't spend the rest of their day chasing up the junior medical staff to get flipping jobs done. How dare we do that? Professional incourtesy, discourtesy.
When can you come here?
Well, some people won't want to hear. But at the end of the day, this is about how do we get rid of unnecessary waiting for patients? Because unnecessary waiting for patients results in harm. Whether it's an hour, 2 hours, a day or 2 days, it results in harm. And you've got to root out your internal waits. There will be some external waits, services in the community and whatever. But if you do a waits audit, a proper waits audit, somewhere between 60 and 70% of your waits will be internal. And absolutely, unless you've done a massive theory of constraint piece of work in this organisation, I guarantee that 60-70% of your waits will be internal. I know that actually because I've seen them today.
Do you think if you put like half-hour assessment decision, if you give them chunks of time, that you get an increase in the number of soft admissions?
No.
Because the junior doctor, and it invariably is, then feels pressured, I've got to make a decision, I'll just admit them.
Well, I think you've just pointed something about that.
Junior doctor.
Yeah, well,
In
there
my
lies
service,
a real
who do you
problem.
think, which admission grade of doctor stands at the front door? Which bed holding specialty grade of doctor stands at the front door? It's the consultant.
There
I don't
is.
want to have people admitted if I don't want to. I just want to get them fixed and get them home. Because for me as a geriatrician, if I admit somebody with dementia who's got unnecessarily got a UTI, I know I may, if they stay overnight, they may decondition. I may have them for 2 to 4 weeks. And I remember the days way back then when I would have 40 inpatients. Roll forward 9 years. Frequently now, despite activity having gone up 30%, I used to have, although I don't do it in clinical practice now for the last 18 months, on my Monday fixed ward round, during the summer months, I may have 0 inpatients. Because if you front load the decision making, you get that. So yes, of course, I don't want to get soft admissions, but that's about deciding what adds value to the patients. And what adds value to patients is senior decision making.
But you could argue that's a total waste of time because you've got a senior clinician at the front door making the assessment. Why don't you know one come down and make the same assessment?
Well, it depends who's setting the. What ED is very good at is ED will set the case management plan and deliver it for those patients that it doesn't admit. For those patients that admit, it needs somebody else, who's an inpatient specialist to set the case management plan, and that needs to be set by the consultant.
But I would guess the ED consultant knows where that patient should go.
They know the specialty.
Yeah.
Absolutely.
So-
but what the patient then needs is to have an early senior review by a consultant.
Yeah.
So we have KEO standards in the UK now, which are slightly weak, which are, Sir Bruce Keogh is the Chief Medical Officer for NHS England, so he's responsible for 56 million population. And he set KEO standards that for between the hours of 8 AM and 9 PM, all patients who are admitted should be seen by a consultant in less than 6 hours. Now that's a pretty weak standard. I'd say it should be less than 4 hours, and ideally less than 3. And those who are acutely ill should be less than 1. Truly acutely ill should be less than 1. Because we know from the NC-POD reports that if there are delays in patients being seen by a senior doctor, consultant level, you have a deterioration in the case management plan, which increases harm and it deteriorates outcome and increases length of stay.
I mean, do you know a model whereby the decisions made at the front door by the ED physicians that goes to a particular place, the patient?
Sorry, say that again.
Do you know of a model where the ED physician actually decides what service the patient goes to?
Yeah, I mean, that's banning the specialty ping pong.
Yes.
So ED.
Because it would always happen. There has to be a referee somewhere.
Yeah. Well, it's very simple. ED is king. Okay. So as soon as ED make a referral to a specialty, that's it. If the specialty then sees the patient and says, actually, it should be the left toe specialist rather than the right toe specialist. I'm slightly exaggerating for effect here. It is their responsibility to get the next person in the queue to see them, because ED's got the next 100 patients coming through. So absolutely categorically, ED decides which specialty the patient goes to. They make the referral, the answer should be yes. If you find that it's the incorrect specialty greater than 10-20% of the time, that's internal learning that needs to take place. I would suggest that it might be slightly difficult here because of the amount of salami slicing specialties you've got and the interface issues with that, and that needs to be simplified, hugely simplified. But if you've got it simplified, ED decide, that's definitive decision, the answer is yes, and then the timeliness of assessment, an early senior assessment. So I'm not saying you can do all of that straight away, but if you move towards that, you foreshorten patients' journey times because they get better, faster and safer. And if they get better, faster and safer, they go home earlier. You've got, when I walked around today, you have got multiple causes for queuing, which are internally generated. And every single one of those queues is at risk of causing harm. Therefore, as a governance responsibility, as a medical director, I would not find that acceptable at all. Because I would never countenance a system that is designed to generate harm. I would spend all my time redesigning the system to drive the harm out of it. Right.
Ian, I've heard you before with this, but the difference this time for me is we've got 4 medical leaders in the room, and we've got a heap of willing people in this DHB to make a real difference. And I think that's growing every day.
Yeah.
But what worries me is for our medical directors, and how do we support them? How do is there anywhere in this discussion where there's a link to someone who can support them? Because this is pretty hard stuff. You're very convincing. You've done it 150 times.
I haven't. No, I've supported 150 organisations.
You've supported. Is that because I think we need some support at your level to have some conversations and support, because I know how hard Caroline's worked with her discussions in the world that she works, that we collectively have created for her to work in. And we've made some progress, but I'm watching the 2 ED folk in front of me nodding, because they're understanding and hearing what you're saying.
Yeah.
But we've got to get it to the next. We've got to get to the next.
Setup. Okay, setup is absolutely crucial. There are things there are the processes that you can improve: ED, internal medicine, specialties, diagnostics, therapies, etc., etc. Those are the things that you run the PDSAs around, the improvement program around. But if you don't do setup properly, all of this will fall on stony ground. Okay, all of it will do. And setup is the one thing that I spend most of my time when I'm embedded within an organisation really stressing. So I will go and meet the executive team and say, you're not out on the floor enough, and you're going to get consistency of message out there. And you've got to talk with intent that this is going to get better, and you will deal with the deviant behaviour. I have no problem with dealing with deviant behaviour, because I start with saying, this is all about patient safety. We heard what you heard what we talked about. We've done a huge communication strategy about our intent to drive down harm, mortality, and get rid of all unnecessary waiting within our organisation. I understand that you seem to have a problem with this. Would you like to explain it to me? And the next stage is a walk in the park, and the next stage is a P45. Okay? So it is, we've got to be very clear about the governance and the leadership behaviours, creating the vision, describing the intent about what good's going to look like, that we make it unacceptable for people not to join the improvement journey. What do you think the risk was for East Kent if we didn't fix that? We were going to get broken up and have an external team brought in who were going to be a turnaround team. Anybody know a turnaround team that's ever worked anywhere? No. Harm rockets when you get turnaround teams in. So the stark reality is, you've got to fix this yourselves, otherwise you're going to have a turnaround team, would be my impression, because that's what happens in our NHS. I'm sure that might happen in your health system. But this setup is absolutely crucial. And there must not be a fag paper, sorry about the phraseology, between the leadership, be that the primary or the secondary or the informal leadership of the organisation, about we are going to take this forward and make a difference. Because what is happening at the moment, with 30 odd medical outliers and over 25% of the cubicles in the ED being occupied, is unacceptable from a patient safety perspective. And I would find it difficult to be able to say, you know, I can leave this for a month or two until we have a board meeting about it. We've got to start tomorrow, because patients are coming to harm today and tomorrow. And if we don't even believe there's harm happening today and tomorrow as a consequence of it, we absolutely have to accept that their experience is pretty poor as it stands at the moment. So it's not really very patient-centric, delaying that implementation. But setup is crucial. Governance is crucial. You say you're going to do it, you go out and talk that you're going to do it, you want to listen to people's views about how they can make it happen. Anybody with a great idea, give them permission to try a PDSA, as long as we capture the learning, and they can then get embedded in an improved methodology to change their processes. But getting everybody aligned to the goal, which is falling mortality, falling harm, falling bed occupancy, guaranteeing that we can get all our tertiary referrals in, making sure that we can get all our electives in, making sure that our infection rates, C. diff, MRSA and norovirus rates fall. Can anybody tell me, does anybody know any clinician in this organisation who couldn't sign up to a vision that describes an organisation that is like that? There may be people who didn't know that could be possibly a vision, but we need to help them to understand that that is the vision. Because if we mess up non-elective care, you can kiss goodbye to elective care in any organisation. In the UK, I'm making it very clear that unless we really have a handle on acute frailty and urgent care of frail older people, we will have no elective care in the NHS within 5 to 10 years. Because we'll have nowhere to do it.
So to add to what Bexy's saying, is there, I know you've been at counties and you've been at other places in New Zealand, and I know counties has embraced the IHI methodology heavily with PDSA cycles. Is there success stories in New Zealand that we can leverage on? Because the challenge is, it's almost to, I'm making an assumption, but it would even be difficult for us just to set that at this stage. And it's, who do we know that
New Zealand's the same as the NHS. Unless it's been invented here, we don't believe it.
Correct.
And unless it's been invented within our DHB, we don't believe it. But actually, we've got to learn from each other. Because actually, my understanding is that everybody in the healthcare business has one thing at heart: is to do good for patients. So yeah, there are. I mean, I'm going back to Wellington on Friday. Okay, Wellington. The 6-hour standard isn't the be all and end all, but it was the worst performer. It was unable to get tertiary patients in. It had high occupancies, had outliers, etc., etc. But in the space of 4 to 6 months, they were delivering their 6-hour standard. Their bed occupancy, they were telling me, and I'm going back to check again on Friday, that they're on the regional hospital site, it had fallen down to 90%, which they hadn't had for ages. And on the Kenny Peru site, which had been running at 100% occupancy, it was down at 69% in winter. Okay. Now I'm going to go back and double check that just to make sure they've continued the improvement, because I suspected actually they could drive their bed occupancy down lower and their mortality come down lower and their harm events coming lower. So yeah, there are examples around New Zealand where that has happened. I am sure that there will be examples around New Zealand. I mean, I haven't been to many others where people have tried things. I mean, Canterbury, DHB, on the frailty pathway, they've dropped the stranded patient metric by 30 odd beds. Okay. That's not good enough from my point of view, so I've given them a bit of a kicking this last week. So actually it should have been 75 by the time I came back. But hey, 30s, you wouldn't sort of give up 30. If you had 30 empty beds, you'd be quite happy about that. But there are examples around New Zealand where they've done that.
And have they used the improvement methodology?
Some have used it. What I am very clear about in all of this, if I start talking to this audience or wider audiences around lean methodologies, IFI methodologies, too much about theory of constraints, statistical process control and special cause variability and common cause variability, I'd just turn everybody off. Guess what about improvement science? I mean, I've been trained in all of those. Guess what it is about improvement science? It's just bleeding common sense, and measure the right thing and know what adds value to patients and focus on what adds value to patients and be very clear of unnecessary waiting. So yes, of course I would encourage, because I've born and brought up, almost, not quite, in PDSA cycles and that sort of stuff. But if you in Leicester, for instance, they'd had a history of improvement methodology that made them sick to the back teeth because it was hammered into them, and people just got disengaged from it. So when I went and worked with them, I just said, look, I'm just giving you permission to try things. Just capture the learning, what didn't work. I didn't formalise it too much. They're now eagerly wanting to get back into the improvement methodology. So you've got to lead people in wanting to do it. You know, you can force a methodology on people, or you can get people to want to use a methodology. But as long as people say we want to improve, we understand what adds value to patients, and we want to reduce the time it takes for people to get the added value. That's a start. So, you know, I've been a senior fellow of the improvement faculty in the UK. I'm supposed to teach improvement methodology all the time. I know what switches people off if I'm not too careful, because I've done it.
I would disagree with you about what you're calling improvement methodology, which I would call improvement tools.
Yeah.
That is the improvement methodology. What you've got on the screen there, that's the improvement methodology.
That's the governance process behind the improvement methodology. Yeah.
That's essential.
Yeah. That if you don't do that,
then it doesn't matter what tools you use.
Yeah, because you won't get. People have not joined a journey and they can't see where they're aiming to get to.
Exactly.
Yeah. You know, I can go all management speak and start saying Cotter's principles of change, you know, blah, 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 blah. And those are, you know, sort of things that I was brought up on. But this is about the governance of saying, are we setting intent? Do we know where we want to get to? Are we going to hold ourselves to account and each other to account in a supportively challenging way? And you know, are we all agreed that that's the goal that we want to achieve? It is achievable. It is, well, what I've seen today, from within your present resources, it is absolutely achievable. Don't get disheartened by that statement. It's actually a really positive thing. It really, really is a positive thing.
Ian, could I ask a question, please? You need a certain critical mass of engaged people,
Yeah.
and you talked about it, that it would be clinicians, which obviously involves medical nurses,
Yeah,
like a
yeah,
whole wide
yeah.
range. Can you give, is there a percentage
No.
of those people? Do you know what I mean? Because one person alone is probably not quite
No.
enough, but do you need a certain volume, or can you
I mean,
do it with?
well, if I put a hard number on it, and if you fell below that hard number, well, there's no point starting. So,
But just a rough guide.
if you have somebody from each profession across the journey, as it were, say if you would just say you're going to start in medicine, for instance, and there was you and yourself and a physiotherapist across medicine and a pharmacist and whatever, that would be sufficient just to manage that process. And then, you know, as a CMO, I'm going to say, well, great stuff, what these guys have been doing, how can we start generalising this? How do we get our early majority to start to join in this journey? I actually believe you've got more than that. I believe you have pockets of people who are itching to do this, but have felt held back by whatever reason. And now it's about giving them permission to do it and encouraging them to do it.
We've got 23 subspecialties that, as an ED SML, that I refer to, and I think that's part of the problem.
It is.
That for me to go and try and knock on 23
No, you can't.
persons' doors,
No.
you, like,
No.
you can't, and you just end up feeling a bit
No.
overwhelmed.
So I've seen, I mean, Basildon and Thurrock Trust, which is from as an organisation, population said it's bigger than this, and they had 6 people to start off with. And they grew that and grew that and grew that, and people wanted to join it. Leicester, who were 160, I mean, it's not, you know, their bed occupancy's fallen, their mortality's fallen, their harm's fallen, but they were 165th out of 165 delivering the 4-hour standard. Last week they were 8th in less than a year. And their mortality's fallen, and their harm's fallen, and they've got empty beds, and patients were going to the right place first time. Now, I'm hoping for them that they have a fallover, because it's very important that you have glitches every now and again, because then you can check your recovery rates. If your recovery rate's a lot faster, then you rebuild confidence. So it's actually quite important that I hope they do get that sounds dreadful, but I hope they do get a glitch to do that. But they started off with probably, just on one side, I've got 3 sides, about 15 to 20 people who really got it. So it's finding out who out there wants to do it and giving permission.
So what do you do with the key people, say at a senior level, who are totally against it, or don't want to bar it, you'll always do what I've done, this is rubbish. How do you handle that?
That's performance management. Okay.
Because you'll get our mortality rate's pretty average with the sector, we're doing all right.
So you like being average, do you? I mean, I say to people, benchmarking is the biggest danger ever. I'm going to use a phrase now which I apologise in advance because it's got a slight swear word in it. It's called benchmarking to crap. I don't want to be average. I want to be top. You are a premier teaching hospital. You don't want to have an average mortality. You want to have the best in the country.
So just take me through the practical steps.
Of how you manage people. Right, okay.
The reason I say why, that all the folk from the UK who come here get one. US care, I think you never understood what happens here.
Yeah.
The first time you put a bit of acid on, say an SMO who doesn't went straight to the union. And it's right in the front page of the newspaper how he's been bullied or she's been bullied by the organisation.
And
it's a degree of complexity you haven't got.
Yeah.
And it's a real issue.
I mean, the BMA is incredibly powerful in the UK, and we have people who are on protracted suspensions or whatever. But but the approach that I would take was, if you take it as based around the patient, that we wanted to say we have dreadful experience for our patients who are waiting long times. We have potential avoidable mortality. Please go out there and find it, because if you're not doing case net reviews and checking to see if they've had perfect care rendered, you don't personalise case net reviews. You get generic themes, and then you look for your harm event rates and go, what are our issues? And you go, actually, guys, we are better than this. As a collective, we are better than this. Are we going to join a journey that's going to get this better? And if there are people who say no, you don't have to pick them off one by one and say, look, I just need to understand, this is about patients and patient quality. I understand about your specialty and you want to develop it, and clearly if we can get our bed occupancy down, that increases the opportunity for us to develop your specialty. Because I understand why people get into situations. The adoption curve, you've got your early adopters, early majority, late majority, and historians. Don't call them laggards, because that's not fair. The reason I call them historians is something happened to them 20 years ago that made them into a historian. And they may well have been an innovator 20 years ago, and they just got fed up by the system not helping them. And if you understand that, you can bring them on board. So it's always about trying to go to the positive side of people about why they're in healthcare. It's about optimal care for all our patients, and accepting that we want to help develop your specialty as well as this specialty as well as that specialty. You will know your people better than I do, and I can't give you a script to use, but it's about being prepared to have the conversation about, at the moment, our experience for our patients is not good. We have, and I'm not getting at medicine here, but we have medical outliers on surgical wards, which is stopping you, surgical specialist X, being able to bring in your patients. If we all join this journey together, we would have zero medical outliers. It's not just about us and them. It could be the responsiveness of surgery, responding to a request for an opinion from whatever. But it's trying to get to their positive side. They're compassionate about the patients in general rather than just specific about their specialty. But if there are people who then continually obstruct, and I don't know the full details of your unionisation. We have the BMA, which is incredibly powerful in the UK. But it is about saying, if those people who persistently undermine the improvement work to the detriment of the organisation of the population being served, as an organisation, you've got to think of a strategy of either getting them on board, or marginalising them, or getting them out. I can't go into, because I don't know the minutiae, but it is as simple as that.
Yeah.
We want all our you want all your specialties to flourish here, yes? All your specialties can only flourish here if we have a really effective non-elective care process. If we have a really effective non-elective care process with falling mortality, falling harm, our reputation rises, and our ability, as a consequence of that, actually your funding your cost base will improve. You will then have money to invest in specialties. You've got to think of a strategy to take it forward. You can't go in at the front saying you will do this, otherwise you're sacked. I mean, I praise it a bit and say you've got to get on board, have a chat, or a walk in the park, and then a P45. That's because I'm here doing a presentation. I can't do the minutiae of it. But it is about getting, the willing. And actually, if you get a social movement that creates that, it is socially unacceptable not to join the improvement journey, it's socially as unacceptable as drink driving, that peer-to-peer apply some of that challenge, This is about trying to flatten the hierarchy. You set the intent from the organisation. You then set the organisation on a track that wants to go to that journey, because they all see the benefits, not only for their entirety of their population, but for their specialty. And then they all peer-to-peer start challenging people. Some people will need some support in being able to do peer-to-peer. But it's the willingness, as I say, if you just go in straight away and say, you must do this, forget it, you've lost it straight away. But if you go, look guys, we don't want to be average on our mortality, we don't want to be average on our harm, we want to be the best in the country. We want to be able to show that we can get the best flows in emergency care, always get all our electives in, and start drawing in more tertiary work, because all of that will improve your bottom line as well. So it's about, you know, finding out what rocks somebody's boat and playing to it, but then managing it.
Because what I found is I go right to my frontline staff and say, what's important to you for the patient journey? And they have the ideas, and it's about embracing, getting them excited about doing a better job, and then using their ideas. So it's trying to find out what's important. Why do they come to work every day?
Yeah. I mean, what went wrong at mid-staffs was top-down command and control. That went completely wrong. A totally target-driven, financially driven model. Top-down hierarchical command and control. What this is about is bottom-up, appealing to everybody's passion about providing excellent care for patients, and harnessing that power of the many to bring about the changes that deliver the outcomes for the population, the individual patient, and the organisation, and getting people to want to join that journey. I mean, I know I sound sometimes a bit over the top, and I'm a bit passionate about this. Hey, I make no apologies about being passionate about it, because all I want to do is to stop people dying unnecessarily and stop coming to harm. That's what gets me up in the morning. You know, that's the only thing that gets me up in the morning, because that's why I went into the profession that I did. And I find it inconceivable that people wouldn't want to join that improvement journey, but they've got to understand why they want to join that improvement journey. You don't just tell them. You get a social movement going, an absolute passion for wanting that journey. And the thing about, you know, the executive teams walking the floor and talking to people saying, how can I help, what can we do, what can we celebrate, what, have you got any ideas you'd like to test and whatever, that's very pricey. It's about encouraging improvement. So permission to try.
So you'd need to get that social movement going before you implemented the banning the patient football, ping pong.
No. You could, I mean, there are, how you implement all of these, you've got to do it in a semi-planned way, but you know, there are certain red rules that you've got to put in place to start off with, and you've got to accept the red rules.
I think the movement's here, but it's how to actually operationalise that.
Well, that's
the next step that needs to occur, and that's the bit that's a little bit difficult in terms of like, how do you actually do it? I think it's like Dick just asked, like, how do you
practically get down from 23 specialties to a manageable amount?
And how do you change, you've got 30 minutes to attend, or the 30 minutes to like kind of make the decision. How do you move from that, from the medical clerk, which can take 2 hours, you know, an hour and a half if they're complex? How do you move away from that mindset? How do you operationalise that? Because that is like heresy to some traditional.
I know, and what you have to do is just keep. East Kent was three sites with a forced merger in 1999-2000. Extremely happy merger. At each of our throats all the time, and it wasn't an easy journey. And the thing that actually got people to want to join the journey was the secret filming the mitzvah. I'm not going to say that's the way. That's a change tool, but everybody said, God, we're better than this, and we have got to come up with a vision. We came up with a vision. We went out and communicated, and we kept on communicating it for months and months and months. And it was the clinical leadership who were fronting that presentation of what the vision was like. And the clinical leadership is the clinical leadership in its primary clinical leadership, the secondary clinical leadership, and the informal clinical leadership. You know, primary clinical leader, it's not your primary clinical leaders or it's not your primary leaders that bring about change. It's if you get secondary leaders and your informal leaders joining that journey and joining that sort of communication strategy of what good will look like. that's when you know that you're going to start getting change starting to happen. But you know, I don't know the entirety of your culture. I don't know all your individuals, and you will know that far better than I do. But one thing I'm pretty certain of is you know what hasn't worked so far. So don't do that again. Try something else, and it is about trying to get people united against the common good for the patients. And for instance, we had completely inappropriate conversations for 2 years before that secret film about reorganisation of services and financial cuts and whatever. And I said, right, for the next year of our improvement programme, I am not going to talk about reorganisation of services, and I'm not going to talk about cuts. I'm going to say we're going to improve quality and save costs as a consequence. Because you know the reorganisation thing just completely set everybody off, you know, on a different tangent. You know, it's as bad as saying to neurosurgery you can't operate on that day and whatever. You know, imagine trying to change a neurosurgical list's time. It's a bit challenging. Let's just focus on that journey, and that's just one example. But you've got to find something that absolutely unites everybody. And I think I'd be gobsmacked if it wasn't to say we want to be the best in the country at delivering non-elective care. Because if we're the best in the country at delivering non-elective care, with falling mortality, falling harm and falling bed occupancy, we can absolutely nail it with pulling in more tertiary work and developing our specialties. Because if you don't, you may not have much in the way of tertiary services left after a while. Sorry about that. I have no inside information, by the way. I'm just sharing you my honest opinion. So it's in everybody's best interest to get this sorted.
Ian, you talked earlier about the proportion of inefficiencies or wastage in the inpatient setting as opposed to external.
Yeah.
And we talked briefly before about some of those social service cuts in the UK that are possibly impacting on the ability to discharge from beds.
They're used very much as an excuse in the UK.
But what work have you been involved in the NHS that looks at the wider health sector picture, so that the primary care and
all my improvement work for the last 12 years has always been looking at whole systems.
Yeah.
Okay, always looking at whole system, absolutely insistent on it.
So bringing primary care into this debate, into the heart of this debate.
Yeah, and you need to work out the timing of that to do that. One thing I think every organisation needs to start doing first is getting its own side of the street swept clean first, before it expects everybody else to improve before then. So, you know, that's why I did that finger pointing thing. 3 fingers pointing straight back at yourself. Get your internal bits sorted out first. But to get the gearing impact that really racks things up over, you know, next 1, 2, 3, 5 years or whatever, you've got to have the whole system approach. Today I focus mostly on the internal bit because that's all I've had time to have a look at.
Yeah.
Okay, that's all I've had time to have a look at. But can I be very clear? If you were to do a true weights audit, 60 to 70% of your weights will be internal to this hospital. Okay. Nottingham told us when we went to them with the emergency case, no, it's all external. And we said, here's a template to do a weights audit. Please go out and do it. They did a really thorough weights audit across every single one of their wards. Huge organisation. And they came back and said, yep, you're right. 7%. And they said, and that's great, because we can do something about it as a team.
But because we work with that frail elderly population, while we're fixing ED, should we not be trying, because the goal, you know, the goal with them is try not to get them in here at all if we can, and that does mean primary care engagement.
Yeah, it does, and for frailty, I mean, there are 2 parts to frailty. There are clearly some patients who are frail and elderly who, if they had an alternative service, wouldn't need to attend ED. They turn up because they aren't there. What I would not sanction is diagnostic nihilism for frail older people around.
No.
You know, what's the cause of their falls and whatever. So we don't. In East Kent, we rarely, unless they fracture, we rarely admit a patient with falls because we had a very proactive falls service. But one of your biggest issues in hospitals in New Zealand and in the UK still is the extent of hospital-based deconditioning for those older patients who are admitted. And we can fix that internally very quickly by having very proactive early intervention for frail older people. That doesn't excessively medicalise them, starts them mobilising early, and is very focused on staying in hospital too long ain't good for you. So but you've got to start somewhere, and I would suggest you need to start on your internal weights, because actually this audience, I presume, is predominantly people from inside the hospital, is that right? You can do something about some of those internal weights tomorrow. To do things across the wider system will take a little bit longer. Okay, it will take a little bit longer. And your patients don't have the opportunity to wait for you to fix the wider system, because they're coming to harm today and tomorrow. So yeah, but you're right, it has to be a whole system approach. The risk is if you get the hospital so efficient and you don't do anything about the wider system, it becomes a supply side driver, it sucks in more work. As night follows day, that happens. So you have to address the wider system, but the speed at which you can start making change happen, it's quicker inside the hospital.
Can we give Southland a chance to answer questions?
Yeah, sorry, I'm sat there with my back to, very rude of me.
Any questions from the team?
I guess it's Janine Cochran here. I'm thinking that actually most of the people over 75, and Stephen, you will have had a look at that data, are in surgical and medical wards. So the drive to
general medicine,
but they're not. We're not talking about just in care of older people's wards. So what we have got is some work that's happening around trying to reduce the bed days. So what you've provided today is going to be really useful for that. I guess in terms of looking at the delays, is there a specific audit that you have that we can just pick up and
there's the IHI waste audit. I can get hold of the emergency care intensive support team's internal, external weight audit tool, but the IHI waste tool is just as good. It's dead easy. It's just opening your eyes and saying, right, we're just going to record which are internal weights, what they are, and group them within diagnostics, within referral response times, within decision, within delivery of care or whatever. So yeah, there are tools out there, but the IHI waste one is a pretty good one. You'll have seen the IHI waste tool.
Because we've done some waste. Yeah, we've done some waiting. What do people wait in hospital for, and waiting audits, and actually people stop seeing it because they're so used to it.
Yeah, that is the problem. The big advantage for me as somebody who comes in externally, I always come into an organisation with fresh eyes, and the key thing is always, when you recruit new staff, over the first 3 months, ask them to tell you what isn't working right in your organisation, because after 3 months they'll no longer see it. Okay, so you lose fresh eyes after 3 months, and you can no longer see the weights in your system. But it is about getting people to open their eyes and re-see the weights that are occurring. So if on general medicine there's a referral for, say, gastroenterology for a discharge critical referral, and gastroenterology don't come until tomorrow or the day after, might that be a possibility? They might take that long to come and see them?
Yeah, they do everything by paper. They don't need to see the patients.
Sorry?
They do it all by paper. They don't often see the patients.
Okay. All right. Well, then we can do another specialty.
But yeah, it could be a couple of days for surgery.
Yeah. Okay. Well, it's 4-hour rule. If it's a discharge critical referral, 4 hours. Sorry, guys. 2 days later, it's too late. And what happens is you become accepting of that delay. So it's been, if somebody has a discharge critical investigation required, or a discharge critical referral, a true one, I mean, not somebody who's got a couple of blisters on their leg and their CRP is 5, that can see dermatology in outpatients. And I've seen people being kept in hospital for exactly that. But if it's a discharge critical referral, it's 4 hours.
Yeah.
But it's about being clear about what isn't acceptable. If you accept unnecessary delays, then you can't shorten journey times.
What you describe is quite interesting about how people in the system fail to see its characteristics, which are warning signals. I mean, the staff's response wasn't patients complaining, it was the mortality adjusted rates showing a blip, which came through a roundabout process. Your Kent one wasn't the patients going into management or that, it was a hidden camera.
Yeah.
Yet, if you ask patients later, such as staff inquiry, you get tons, you get an enormous amount of information from patients about how dreadful the situation was for them and their relatives. But yet, as a standard in terms of reporting and understanding what the key, I suppose the key indicators for a service, we hardly ever do it.
No. And that's why those 4 questions for patients. If you go and ask every patient, you know, on some wards, can they answer those 4 questions and describe precisely what's going on? You know, if they won't be able to answer it, then you haven't actually communicated the case management plan effectively.
And using patient journeys, actually talking to patients, filming what they feel and showing that to staff. Really powerful.
Patient stories are really powerful.
They're really powerful.
Yeah. We tracked back in 2000, we tracked 100 patients' journeys, really and we presented that to every clinical forum saying, what are we doing?
Yeah, and that could be used as a leverage point.
Yeah.
The discharge critical referrals is a really good terminology in terms of what it says to me if I'm receiving a referral.
Yeah.
When you're an inpatient, what isn't a discharge critical referral? I'm trying to understand in terms of things needed to be done, isn't.
Well, I mean, I simplistically asked myself, if I was seeing this patient in outpatients and I found this other thing that I wanted to refer to somebody else, I wouldn't admit them to wait for that, you know.
Okay. So this thing needs to happen to get the patient out. So pretty much we should only be doing discharge critical referrals, and other referrals are
can be through the outpatients. Yeah.
Okay, got it.
Yeah.
But even that terminology is quite clear. Hello, I've got a referral to, I've got a discharge critical referral that says if I don't see it in 4 hours, the patient's not going home.
And from radiology point of view, for instance, discharge, you know, many out-of-hours radiological services some will only say we only do life and limb-threatening diagnostics. Okay, that's important. They must do those. But actually, if I've got somebody who I have a high clinical index of suspicion they've had a pulmonary embolism, but they're hemodynamically stable and their troponin is normal, i.e. they've got no signs of right heart strain, you know, whatever, whichever index you want to use, I want the CTPA now. Because if it's 9 o'clock at night and this person's saying, oh, I'll go home, I can send them home. Send them home with Clexane or whatever, you know, molecular weight heparin you want to use without a CTPA is not good medicine. Okay, so that would be a discharge critical CTPA request. And when your systems are really slick like that, you end up not having delays.
Well, one of the issues is occasionally we do, is what you alluded to, occasionally we do try and institute something. And an example I'll give you, because it's not mine, and it's not my baby, is we introduced a TIA clinic, so patients wouldn't have to come in 3 times a week. Well, and it's been seen by GPs and occasionally junior ED staff as a funnies terms clinic. And despite the consultant repeatedly saying, these are people who clearly have TIAs, it's just like, well, this is a nice new thing we've got. And pretty much every department that does something well gets an influx of
I stress the importance of the risks of supply-side drivers.
So
okay,
that needs to
hot clinics, whether it's TIA or GI, whatever, will always be a supply-side driver. But there are things that you're doing at the moment that are causing unnecessary delays. So let's get rid of those unnecessary delays. Before you start inventing hot clinics for this and hot clinics for that, let's start focusing on the inpatient journey time so that we cut down all the unnecessary delays, pull patients through the journey so they get seen, sorted, and then discharged. And then if we find we want to run an ambulatory emergency care process, you see what people talk about hot clinics is that's a way of delivering ambulatory emergency care for adults. There's a directory of ambulatory emergency care, 49 clinical scenarios that we saw in the UK that could be people frequently admitting them, such as pulmonary embolism, but in some places they're actually managing them very safely on an ambulatory basis. If you set up a hot clinic for the breathless patient to do that, you just have a supply-side driver. Ambulatory emergency care is a mindset. Every patient is ambulatory until proven otherwise, if it comes through the non-elective pathway. Just exactly the same as if you're thinking about day case surgery for elective surgery. Surgeons are taught to list patients for day case surgery unless they can prove they aren't for day case surgery. So the mindset is ambulatory until proven otherwise. And that's how you deliver it through your assessment delivery process. And then you might start having an area that you can do it from. But if you start advertising it as a hot clinic for something, you'll get a supply-side driver.
I mean, I go there as an example. There are sort of other things you can do internally, like if you're responsive to the surgical house officer, they tend to start to renew instead of their own. If that sort of behaviour, it's very hard to get on top of.
Yeah, but that's where you need to start saying, right, what is a discharge critical referral, and who makes that decision about a discharge critical referral? So if I left my FY1, first year, to decide on everybody who needed to have a CT scan, I would have loads of delays in my CT scanning. And under my name, my CTPA positivity rate, which was running around 20-21%, would plummet down to about 4%. I wouldn't be very happy about that. So it is my responsibility to make sure that the team that I work with use diagnostics appropriately, right? So if you let any bloke refer to surgery, of course you're going to get a supply side driver, but if you've got to standardise the process.
And
then wrap the training around it. So you say to your registrars, you want to make this referral, right? Tell me why you want to make that referral. Why does it have to be an inpatient referral and not an outpatient referral? Why is that discharge critical? Because then you're teaching them how to run the system better. But yeah, I absolutely agree. If you just say all FY1s, you must refer everybody and they must respond within 4 hours, you get a complete mayhem. You've got to control the you've got to manage the process, and that's how you work it out as a team. Any other questions? I'm going about this for a long time. It's impossible for me to go through the methodological approach in detail just in one afternoon. What I wanted to leave you with today is the belief, not just hope, but absolute belief that you have all the resources and all the expertise to completely re-engineer your emergency care pathway that will completely abolish all your need for medical outliers. And actually, mortality will fall, harm will fall, unnecessary waiting will fall. You'll be able to pull in all your elective cases and bring in more tertiary care. That has to be right for this business. It has to be right for what we're here for in healthcare. But it has to be clinically driven. I can't stress that enough. It has to be clinically driven, absolutely owning what good will look like. I'll leave you on that then.
Very good. Thank you.